Hello. Thanks for joining me for this discussion about the critical need for substance use disorder systems of care. My name is Rachel Post, and I am with the Technical Assistance Collaborative, which is a nonprofit organization that provides policy and leadership, technical assistance, and expert consultation to government agencies, policymakers, advocates, foundations, and service providers. All of our services advance proven solutions to housing and community-based support needs of low-income people with disabilities and people who are experiencing or at risk of homelessness. TAC works with funders and clients in every part of the country, contributing policy and subject matter expertise in 5 focus areas: homelessness, affordable housing, mental health and substance use, community integration, and Medicaid, while centering racial equity and social justice. I have been working in this field for about 25 years. And prior to working with the Technical Assistance Collaborative, I worked both for Central City Concern in Portland, as well as Colorado Coalition for the Homeless in Denver. In those positions, varied positions, I served as Director of Substance Treatment Services. In Denver, I designed and stood up the Portland Chronic Homeless Housing First Team, the Community Engagement Program at Central City Concern, as well as a similarly funded initiative in Denver called the Denver Housing First Team. I oversaw street outreach programming, employment programming, and supportive housing services, both using Housing First as recovery housing. So thank you. And you can advance to the next slide and we'll talk about our agenda. So there are going to be 2 items I'm going to be highlighting today. So the first one, I really just want to provide an overview of how combined interventions save lives. So we'll talk more about that in just a moment. But basically, all the different systems that need to be aligned in order to really address homelessness and to support health and wellness for people who have substance use disorders who are experiencing homelessness. And then I'm going to highlight briefly work that I did for the Homeless Strategic Initiatives, a report that myself and 2 of my colleagues issued in December of 2022, specific to the need for a substance use disorder system of care in the Portland metro area. Thank you. Next slide. Okay, why are we here today? Well, I'm certain that all of you who are in attendance understand the gravity of what is happening all around the country as it relates to substance use and overdose, as well as the disproportionate impact to communities of color. So first of all, I want to highlight this, and again, I'm sure folks here know this, but Oregon has the highest rate of methamphetamine and prescription opioid use in the nation. Oregon ranks first in the nation for the percent of the population needing but not receiving treatment for substance use disorders, and second in the nation for deaths due to drug use, and 6th in the nation for deaths due to alcohol. The range of substance use among those experiencing homelessness is 58 to 88%. According to the Oregon Health Authority's Public Health Division, individuals experiencing homelessness are at the highest risk for unintentional overdose deaths. In Multnomah County, nearly 80% of all deaths of individuals experiencing homelessness involved substances last year. And of these drug-related deaths, roughly half involved methamphetamines. Since 2015, overdose deaths have been rising most rapidly among Black and Latin communities. In HUD's 2019 annual homeless assessment report, it noted that African Americans have remained considerably overrepresented among the homeless population compared to the US population. African Americans represented 16% of Multnomah County's homeless population, but only 7.2% of the general population for the county. American Indian Native Alaskas made up 11.6% of the PIT homeless population, but we're only 2.5% of the general populations, and Native Hawaiian Pacific Islanders made up 3% of the homeless population, but only 1.1% of the general population. Next slide, please. So now we're going to talk about this concept of combined interventions saving lives. I really have been thinking about this a lot over probably the last, I'd say, 5 or so years, about this conundrum of, this mantra and principle that has been really centering housing first nationally for really about 2 decades, right? Back when Phil Mangano, before many of your time, in 2001, and Sam Zamberas promoted the concept of pathways to housing, housing first model as really being central to ending homelessness. And as I've thought about that, I've thought about, well, yes, absolutely. But we also really need to highlight all of the different services that have to be scaled up in order for that to work. And so first, I wanted to talk about, and I really want to give credit to my incredible colleague, Dr. Lamont Green, who is the TAC Director of Equity and Inclusion, and who helped conceptualize the significance of culturally responsive systems for me, and in the paper that you'll see later. So a culturally responsive SUDS homeless system of care must be designed using a racial equity lens in order to reduce racial and ethnic disparities. We have to operationalize cultural responsiveness by ensuring that policies, practices, attitudes are grounded in that are trauma-informed and health-centered awareness of the cultural assets, indigenous knowledge, and resiliency of communities of color. State and local governments, providers, philanthropy, policymakers, and those represented of the marginalized groups must examine how they may be reinforcing patterns of oppression instead of truly working to eliminate disparities. In order to restore power to historically disenfranchised communities, state and local systems will need to engage with communities impacted, to share decision-making and to lift up solutions that are developed by those most directly affected by substance use and homelessness. As examples, communities must publicly recognize how the impact of the war on drugs profoundly affected people of color and how it was manifested through racial discrimination by law enforcement through the 1980s. A culturally responsive system of care requires not only the shared decision-making, but the results of those shared decisions that relate to lifting up community-based providers operated by and for communities of color to serve Black, Brown, and Indigenous individuals in culturally relevant programming, hiring practices that increase the availability of Black, Brown, and Indigenous employed in leadership and direct service provider roles, onboarding and ongoing training practices that hold accountable all those interfacing with marginalized clients and tenants, program participants, to deliver culturally responsive care. I understand that Measure 110 really was a vision for how to operationalize some of those culturally responsive practices, and commend Oregon for really putting money towards funding culturally responsive care. Next slide, please. Okay, so we know that as a foundation, we have to have a culturally responsive system. Next, we need to ensure that harm reduction is a core element in this effort. Most of you know this, right? Harm reduction employs a non-judgmental and non-coercive approach to authentically engage people with SUDS, substance use disorders, in services they desire, and positions them as the primary agents, both in their own care and ultimately in the design of the substance use disorder programs and policies. This is done by meeting people where they are and on their own terms, and incorporating a spectrum of strategies that may serve as a pathway to additional treatment and recovery supports, including housing. I want to emphasize that last statement. That may serve as a pathway to additional treatment recovery supports, including housing, right? So often in my experience over the last 20 years, I'm familiar with housing first programs, identifying that they use harm reduction, that they are placing people into housing, that they are helping people to access safer use kits. What I don't hear a lot of is the assisting people to move to engage in treatment and recovery supports. And that's something that's critically important because, and we'll talk a little bit later about the value of recovery peer support services, but unless people who are being engaged through harm reduction and housing are able to interface with people who have previously been homeless, been incarcerated, have struggled with substance use, it's really hard for people to imagine a future that doesn't involve ongoing substance use, a future that can include employment, that can include being reunited with one's family and friends, and a future that involves even, home ownership. So I really want to emphasize that point about the value of harm reduction, that it's not just stopping when we place someone in housing, but it's ongoing to move individuals towards an interest in treatment and recovery. So harm reduction requires outreach and engagement that conveys high empathy, appreciative inquiry, being curious about what's important to an individual, how they see themselves, and when conducted in unsheltered encampments, the ability to immediately meet basic needs. So offering hygiene kits, safer use harm reduction kits, snacks, water, clean socks, all of the things you all are doing, right? And support access to desired healthcare, services, and housing in a timely manner. Harm reduction must be utilized throughout engagement. It's not a one and done. Throughout the engagement process, program participation, and transitions out of programs. Next slide. Okay, now we're going to talk about, again, this is a system of care, right? We've got culturally relevant, responsive services. We've got harm reduction. Without safe, affordable housing, effectively addressing substance use is nearly impossible. We know this, right? Yet those who are experiencing homelessness, who are actively using, face multiple barriers to accessing and maintaining housing. Barriers include criminal records, poor credit history, outstanding rental arrears, and behaviors that impair ability to be a safe and responsible tenant. Supportive housing works because it combines affordable housing assistance with voluntary and individualized wraparound services that can help people to access and sustain their housing. I want to pause again here and draw our attention to the word voluntary and individualized, right? Too often, communities or programs identify that, well, this is client-centered, and this subset of our tenants don't want to participate in services, and that's fine. It is voluntary, but that doesn't mean that us as the intensive housing case manager or an ACT team member, that we're not continuously working to develop the rapport and the trust, the relationship that helps people identify that maybe they do want to engage with us. Maybe that we are there to support them into treatment, into coming up with ideas about how to reunite with children, identify how to help them to resolve some of the expungible criminal record points. So it's really our duty as creative and intensive and client-centered interfacers, whether that's case manager, whether it's an ACT team member, to really continue to work on building that relationship. So supportive housing models designed to meet the express needs of people who are actively using include permanent supportive housing, you all know this, and recovery housing. They both have a place and a role in meeting the needs that are expressed, that individuals express that they want. So an emphasis on choice, and we came up back when I was at Central City Concern, the concept of housing choice. So emphasis on choice is highly recommended in order to align with the stated needs and desire of people who are using substances. Next slide. In addition to harm reduction, to supportive housing that's available with the level of supports required, we also need high quality on-demand treatment. It has to be available without delay when a person expresses they're ready for it. You all know this. You all have seen the implications of not having the availability of on-demand treatment every day. Barriers to treatment admissions, such as lack of insurance coverage, transportation challenges, capacity limits, or ineffective admission processes result in lost opportunities and even avoidable loss of life. Low barrier treatment options seek to engage people who use drugs when they are ready by being flexible, available in convenient locations, including via mobile services, and offer medications with minimal limitations. Next slide. Finally, in this circle, this continuum, this system, recovery supports are offered by people who have lived expertise in overcoming substance use disorders and are utilized to overcome feelings of helplessness and hopelessness. Again, that helplessness and hopelessness. If I am living on the streets and I am struggling with polysubstance use, unless I'm seeing somebody else who has struggled with that, who perhaps I was incarcerated with, who perhaps was my former dealer, who perhaps was my buddy that I used with, if I see that person now is in recovery, is employed, has been reunited with family members, that is going to make me feel more hopeful that I could envision a future myself similar to this person. Whereas if it's me, Rachel Post, person with zero experience of substance use or homelessness, telling somebody that they should feel hopeful, that doesn't work that way. Recovery support services are often available through mutual aid groups such as Narcotics Anonymous, Smart Recovery, through recovery community organizations, and or through peer recovery coaches and mentors. Some of my best mentors when I was working in Denver and in Portland were people who were formerly homeless, who were in recovery. I learned far more from them than I ever learned in social work school. Recovery supports can be used to foster wellness by facilitating linkages to and coordination among health, behavioral health, and social service agencies, legal systems, and housing operators. Also, supportive employment services are integral to addressing the health-related social needs of individuals who are or have experienced homelessness and who are impacted by adverse substance use. Next slide. All of these interventions must be working in coordination to treat substance use as a chronic disease that is relapsing in order to optimally promote improved health, wellness, and connection for the long term. Without any one or more of these that is available to meet the need, we can't honestly say that any one of these interventions doesn't work. We can't write off treatment. We can't write off harm reduction or recovery support services. We can't write off housing first or recovery housing. We need them all to be available to scale before we can really know what other challenges the folks in our community are facing where they can't access all of those services in a coordinated, seamless manner. Next slide. You can learn more about this concept of combined interventions through these 3 additional resources. The top 2 were developed by myself and my wonderful colleagues at TAC on behalf of the SAMHSA Homeless and Housing Resource Center. The first one you'll see is sort of a tip sheet. The second is a recorded webinar with my colleague Lamont Green, who shares his own personal story of homelessness, of being a veteran, identifying as a Black gay man who struggled with addiction to methamphetamine. It's a very powerful webinar. And then the third document is an issue brief that myself and my colleagues at TAC we put out, which led to these SAMHSA resources. Next slide, please. Now I want to turn a little bit, pivot to some work that I did with my tax senior consultant, Rebecca Boss, and senior associate, Amy Horton, on behalf of the Homeless Strategies and Solutions Initiative. So TAC developed this report utilizing key informant interviews. We were engaged in September of 2022 and issued the report in December of 2022. And what we did was we utilized key informant interviews, available data, and existing reports, including the Homeless Management Information Systems Annual Progress Report and the OHSU PSU gaps analysis. And I'm not going to read to you the overview of what's in the report. You can find a link to that later. Next slide, please. You can see here the list of key informants that HSI included or asked for us to meet with. So here's the list here. And on this next slide, you can see, and you're not going to find any surprises here, right? That these were the immediate challenges and the number of key informants who endorsed this as an immediate challenge and the percentage. So there's no subsystem of care. Insufficient capacity of residential and or outpatient treatment, insufficient funding, workforce shortage, turnover is huge, unable to engage and treat high acuity populations, and insufficient housing to discharge clients to. Next slide. So with the findings from this report, TAC made 5 recommendations to HSI in order to address the critical need for a substance use disorder system of care. So number 1, as the entity that covers 385,000 Medicaid enrollees in the Portland metro area, Health Share of Oregon should play a central role in convening key stakeholders to create a substance use disorder system of care executive body. In this recommendation, we identify that it will be important to engage the governor's office, the Oregon Health Authority, the CCOs, and county behavioral health authorities in a conversation that identifies the needs for a payer-driven substance use disorder system of care executive body that will work to align federal, state, and local funding for the continuum of harm reduction services, treatment, supportive housing, and recovery support services required to address the multifaceted population health needs of those experiencing homelessness with active substance use. And this will require advanced data exchange that coordinates multiple federal, state, and local information systems. Number 2, engage major payer organizations to back the planning and engagement of key partners in the and launch the executive body. So here, further, we talk about the importance of securing buy-in also from people with lived expertise and communities of color, and how critically important that will be to the entire process of planning, building, and implementing a substance use disorder system of care, as well as advocating for additional funds to close the gaps identified in this report. In our 3rd recommendation, we identify that it will be important to engage an academic partner and other subject matter experts to evaluate the implementation and efficacy of the subsystem of care, utilizing clear metrics and qualitative analyses. Furthermore, the evaluation should include defined continuous quality improvement processes that would be reported for the first 3 to 5 years of implementation. And it may be beneficial to engage system alignment, subject matter experts, academic and/or technical assistance entities in the planning. In our fourth recommendation, we identify that it will be important to develop a process to identify barriers to increasing capacity. And here, efforts to expand capacity should include both traditional and non-traditional partners. More work needs to be done to understand the challenges to current provider networks in expanding beyond existing capacity, as well as engaging non-traditional providers to expand beyond their existing capacity. An evaluator can document the efficacy of engaging faith-based organizations, BIPOC organizations, and those with lived expertise in the planning and oversight of a substance use disorder system of care. Our final recommendation, won't surprise you, is to create a data infrastructure system. So here, we recognize that across system data infrastructure to support a substance use disorder system of care needs to include housing status and homeless service involvement, and would provide actionable data in a timely fashion, guide decision makers in evaluating impact of efforts, provide real-time resources, and establish a system for tracking referral outcomes. We support current efforts being led by a CCO all claims analysis of key cohorts at risk of homelessness that will help to understand system capacity and gaps. In closing, in order for a subsystems of care to be fully successful, we want to emphasize that both the workforce and treatment capacity issues must be resolved. Without adequate capacity, client flow across the system won't occur, and the workforce supporting the continuum experiences the moral injury of coordinating care of the most vulnerable clients to nowhere, often to return to homelessness, relapse, and harm rather than the potential for recovery, health, and wellness. Next slide. Thank you very much. If you're interested in more information, feel free to check out TAC's website or send me an email. Thank you so much for having me.